Hey everyone, and welcome to This Explainer. Today, we're basically stepping into the shoes of a neurological detective. We are going to take a massive, top-down, geographical journey right through the human nervous system. We'll start at the very top, looking at some really fascinating cranial pathologies, and then work our way all the way down to the peripheral spinal roots. It's honestly this incredible map of cause and effect, where a tiny microscopic structural change can result in these massive clinical mysteries.
So here is our agenda for today. First, we'll cover brain lesions and fluid flow. Second, head trauma and hemorrhage. Third, diagnosing spinal disc herniations. And finally, number 4, critical neurological contraindications. It's a lot of ground to cover, but we're going to logically unpack it all by moving straight anatomically downward.
Okay, let's dive into section 1, brain lesions and fluid flow. We're starting right inside the skull.
Let's kick things off with a classic clinical mystery. So picture this. We have a 40-year-old female recently diagnosed with small cell lung cancer. A scan reveals she has multiple small tumor deposits, but they are specifically located at the gray-white matter junction of her brain. Now you might be wondering why there. Well, here is the physiological reason. As blood vessels travel from the gray matter into the white matter, the capillaries taper off and get really narrow. They basically act like a physical sieve, literally trapping tumor emboli that are traveling in the bloodstream. And because small cell lung cancer is incredibly sensitive to both chemo and radiation, the standard management here isn't surgery. It's systemic chemotherapy combined with whole brain radiotherapy.
Now, when we look at the hierarchy of these brain metastases, lung cancer is statistically the reigning champion. It accounts for a whopping 40% of all documented cases. That's followed by breast cancer at 15%, and then melanoma and renal cell carcinoma, both sitting at 10%. But here's a really crucial example for you. While lung cancer is the most common source overall, mostly just because of how frequently it occurs in the general population, malignant melanoma actually carries the highest relative risk. So if a patient has melanoma, that specific cancer has a severe targeted propensity to seed the brain.
All right, let's shift gears slightly from tumors to fluid dynamics. The human brain literally floats in cerebrospinal fluid, or CSF, and this fluid flows through a very precise internal plumbing system. So the big question is, what happens when that flow is suddenly obstructed? Imagine a large mass like a colloid cyst sitting right inside the third ventricle. Or maybe there's a congenital narrowing called aqueductal stenosis right between the third and fourth ventricles. What is the actual mechanical result of that blockage?
Well, the result is hydrocephalus, but the specific type of hydrocephalus absolutely dictates the treatment. On one side, we have obstructive or non-communicating hydrocephalus. This is a mechanical, physical block directly inside the ventricular system. The fluid literally cannot get out. It's like a blocked pipe. On the other side, we have communicating hydrocephalus. In this case, the ventricular pathways are totally wide open, but there's a failure of the CSF to absorb at the level of the arachnoid villi. This is often caused by scarring from meningitis or an old bleed. It's more like a clogged drain. Understanding this mechanical difference is absolutely key to knowing if a patient needs an emergency ventricular decompression.
Moving right along to section 2, head trauma and hemorrhage. We are looking at vascular emergencies now.
Okay, imagine this scenario. A 6-year-old man takes a tumble in a park. It's a super minor head injury. I mean, so minor he might even forget it ever happened. He is completely stable, totally fine for a whole month. But then, weeks later, he starts getting these severe headaches and his neurological status begins to rapidly deteriorate. What on earth is happening inside his skull 30 days after a simple, everyday fall?
The culprit here is a chronic subdural hematoma. You see, because of age-related cerebral atrophy, the brain shrinks just a tiny bit over time, and that stretches out the fragile bridging veins. That minor fall in the park tore one of those veins, causing a very slow, very low-pressure bleed. And if we track this on a CT scan, it reveals a remarkably precise timeline. On day 1, acute blood is hyperdense. It shows up bright white on the scan. Over weeks 1 to 3, it becomes isodense, meaning it essentially blends right in with the surrounding brain tissue. But by week 4 and beyond, progressive osmotic lysis of that blood clot drives fluid accumulation. It turns hypodense, or completely dark. It's expanding incredibly slowly, eventually causing that delayed, massive pressure effect.
To really grasp how insidious this is, we have to contrast it with its much more aggressive cousin. Extradural hematomas are high-pressure nightmares. They happen when an artery, usually the middle meningeal artery, is injured, literally ripping the tight dura mater right off the skull bone. Subdural hematomas, like the one we just talked about, are slower venous leaks from those fragile bridging veins. One is basically a ruptured high-pressure hose, the other is a really slow, sneaky drip.
And of course, we have bleeds that aren't caused by trauma at all. A spontaneous subarachnoid hemorrhage usually happens when a congenital saccular aneurysm, what we often call a Barry aneurysm, just ruptures. Because the major arterial structures of the circle of Willis travel directly through the subarachnoid space, a rupture here doesn't create a localized, tight blood clot. Instead, that blood spills out freely, washing throughout the basal cisterns and tracking deep into the brain's fissures. Before we leave the head and neck entirely, we really need to look objectively at the mechanics of severe neck trauma. There is a stark pathophysiological difference between suicidal hanging and judicial hanging. In a suicidal hanging, which is typically a low-velocity constriction without a long drop, death is driven by cerebral ischemia. The jugular veins and carotid arteries are occluded, completely stopping blood flow to the brain. Judicial hanging, however, uses entirely different physics. It relies on a mathematically computed long drop that delivers massive axial traction. This sheer mechanical force causes a fracture dislocation right at the C2-C3 level. That's the classic hangman's fracture, resulting in an immediate transection of the brainstem.
All right, moving down the spine to Section 3, diagnosing spinal disc herniations. Let's map out some root damage. So, say we have a 44-year-old guy who has suffered some localized trauma. He comes in with neck pain, but more importantly, he has noticeable weakness when he tries to extend his wrist, and he's got numbness running down his lateral forearm. In neurology, we know these aren't just random symptoms. They are perfectly precise diagnostic breadcrumbs. They point directly to exactly one compromised nerve root. So which one is it?
It is the C6 nerve root. Every single spinal nerve has what we can call a neurological signature. For C6, that specific signature is weakness in wrist extension, sensory loss right over the lateral forearm and the thumb web space, and a depressed brachioradialis deep tendon reflex. When you see this exact triad of symptoms, you know exactly where the injury is before you even order an imaging test. Though, of course, an MRI is still the gold standard here to evaluate the soft tissue disc and anatomy and actually confirm that acute cervical disc herniation. Spinal anatomy is honestly incredibly predictable. We just covered C6, but actually, if the herniation was slightly higher up at C5, the patient would instead have weakness in their deltoid and biceps, with numbness isolated to the lateral upper arm. If it was lower, at C7, which by the way accounts for nearly 70% of these cases, they'd present with triceps weakness, essentially giving them a wrist drop, and numbness tracking strictly down to the middle finger. It is a flawlessly wired system.
And this exact same concept of mapping applies when we jump way down to the heavy lifting joints of the lumbar spine. Lumbar disc protrusions are heavily concentrated at the L4-L5 and L5-S1 junctions, mainly because of the immense mechanical shear stress we place on our lower backs every day. An L4-L5 herniation compresses the L5 root, which creates a functional foot drop and weakness when trying to extend the big toe. But an L5-S1 herniation compresses the S1 root, and that uniquely mediates the Achilles tendon reflex. So if a patient has a diminished ankle jerk reflex and numbness specifically on the lateral edge of their foot, boom, you immediately know you're dealing with L5-S1.
Which brings us to our final stop, Section 4, critical neurological contraindications. These are the crucial life-saving protocols. A lumbar puncture, or a spinal tap, is an incredibly vital diagnostic tool. We use it all the time. But there is a very specific scenario where inserting that needle into the lower spine is absolutely contraindicated, and doing so can actually be instantly fatal. It all comes down to the simple physics of pressure gradients between the skull and the spine.
Let's look at the lumbar punctured contraindications matrix. The absolute most critical red flag here is raised intracranial pressure, or ICP. This is usually caused by a space-occupying lesion, like a tumor or severe hematoma. If the pressure inside the skull is dangerously high and you go and puncture the dural sac down in the lumbar spine, you suddenly vent that pressure from below. That extreme pressure gradient violently forces the brain downwards, causing a fatal tonsillar herniation, literally crushing the brainstem right into the foramen magnum. There's no coming back from that. That is exactly why clinical signs of raised ICP like papilledema or sudden focal neurologic deficits mean you must, absolutely must, get a head CT scan before you even think about doing a lumbar puncture. A couple of other major contraindications to keep in mind include local skin infections right at the needle site or severe coagulopathy where the patient just cannot form a blood clot safely.
So, think about the journey we just took. We've traveled from the narrowing capillaries of the brain's gray-white junction through the fluid ventricles, down the cervical and lumbar nerve roots, all the way to the fluid dynamics of a lumbar puncture. How does mapping these incredibly precise neurological pathways change how we intervene? Well, it proves that the nervous system isn't just some random biological mystery. It's a beautifully structured, highly logical mechanical map. When we understand the physics of pressure, the geography of nerve roots, and the timelines of blood coagulation, we don't just guess at diagnoses, we deduce them with absolute precision. So I'll leave you with this thought. If a simple reflex relies on such flawless mechanical engineering, what other undiscovered mysteries are perfectly mapping themselves out in your nervous system right now? Thanks so much for joining me on this explainer. I'll see you next time.